I mean, I think that's a great question. I think that's sort of something that we wanted to try and handle and tackle with our study. And I mean, I think overall, I mean, checkpoint inhibitors have sort of transformed the landscape of cancer care overall in the past like decade or so. And especially in cancers like melanoma and lung cancer, you see a lot of these patients who are able to, survive for a lot longer with the use of ICIs. And I think, they've been incorporated now into bladder cancer for both metastatic and advanced cancers as well. I think some of the main trials that have sort of led to the approval of ICIs in bladder cancers, so in the first line setting, Keynote, 052, demonstrated that Pembro was able to generate a response rate in a good portion of patients. And subsequently, in Keynote 361 also actually did a randomized trial of Pembro versus chemotherapy. Although 361 didn't actually show an overall survival or progression-free survival benefit, because 052 did demonstrate that there was a response rate in patients who are not eligible for cisplatin. This eventually led to the FDA approval of Pembro as a first-line treatment in patients who are not able to get platinum therapies. And then in the salvage setting, so this is patients who have progressed or recurred on platinum-based chemo. Some of these medications have been approved as well. So Keynote 045 sort of showed that Pembro would lead to an overall survival benefit in patients in the salvage setting. And then additionally, other drugs like nivolumab in Checkmate 275, as well as avelumab, which is in Javelin solid tumor, these also showed a response in patients treated in the salvage setting. So this eventually led to their approvals as ICI therapies, for metastatic bladder cancer. I think the strongest evidence that we have for ICI use in bladder cancer probably comes from the Javelin Bladder 100 trial, which looked at avelumab, but in a first-line maintenance setting. So this is essentially patients who got chemo and basically did not progress, so either responded or sort of stayed the same. These patients were either put on avelumab as maintenance or just standard of care. And this trial actually showed an overall survival and progression-free survival benefit for those patients. So essentially, now we have ICIs that are FDA approved in the first line setting, the first line maintenance setting, and as well as the salvage setting. We first looked at trials that are inclusive of ICIs in the metastatic bladder cancer setting, but we really want to hone in on the durable survival that these may be able to provide. So we essentially restricted it to trials that had FDA approval or had ongoing FDA approval, because there were several medications that we were looking at, but the FDA approvals initially had accelerated approvals, but they eventually were withdrawn because later studies demonstrated that these medications didn't actually provide sort of survival benefit.
But sort of to give a little bit more background, sort of the impetus for this study was obviously there's a subset of patients that respond to these drugs, and we do see increases in median overall survival. But immunotherapy sort of has this halo around it in many cancers, but among them urothelial cancers, in terms of the impact it's had on survival, but also sort of how we view the therapy as being maybe distinct from our existing sort of cytotoxic chemotherapies. That there's this idea that we do see long tails in the survival curve and long-term durable responses. And so we wanted to sort of address that question. Is that something that we see in the clinical trial data? And it's hard to look at because trials are done for a certain period of time and then they end. And they're obviously sort of powered to look at median overall survival or median progression-free survival. And so we don't necessarily have the complete interval. But we said in these trials that we have, are there patients who have lived for very long periods of time? Do we have sort of data to suggest that there is this sort of long tail of the survival curve? And that's what sort of the impetus for the study in the first place, was to try to ask that question directly. And so what we sort of landed on was, can we look at the number at risk? Because that's saying, either patients were sort of, their follow-up had ended for, a variety of reasons, or they progressed, or they died of their disease. And that would be sort of the reason for that number at risk to sort of fall over time. And so that was really the impetus for our study, was to see, is this immunotherapy sort of halo warrant it. Right. So I think anecdotally, we've all seen in our clinics, me included, some patients who do have these long-term durable responses. So that's not to say that that doesn't happen. But, in these sort of seminal trials of immune checkpoint inhibitors, we don't see that. So we don't sort of have data for patients sort of having these very long-term durable responses for urothelial cancer. That's not to say they don't exist. And some of that is, it sort of reflects maybe the duration of follow-up, not necessarily that everyone, has progressed or died of their disease, but we don't see evidence for that in clinical trials. And unlike other cancers where we very clearly do see evidence of these long-term durable responses and sort of long tails of the survival curves, like melanoma or kidney cancer. And so I think that, this sort of is maybe a little sobering with regard to a lot of the enthusiasm around immunotherapy, which is okay. It doesn't mean it's not effective and that, we shouldn't use these drugs, or that they shouldn't have been approved. But I think it sort of reflects that median overall survival increases don't necessarily, translate into durable long-term survival. And sort of that distinction is important.
Our study does have its limitations, and I think because we rely on published clinical trial data, and we obviously see that sharp drop in the number at risk as you go through each of these trials. On one hand, that's like a reflection of maybe the limitations of the medications themselves and what they can provide for patients at this time. And the other major limitation is that the follow-up time is limited, and so maybe we're just not able to capture any more of these patients who may be benefiting. And as Dr. Shoag had said, and I think anecdotally in the clinic, and a lot of medical oncologists may attest to this, is that they have patients who are on these medications for a long time. And unfortunately, because we rely on only clinical trial data, we're not necessarily capturing that within our analysis.
I think one of the things that sort of prompted our work too is that there's it tends to be sort of these hype cycles with any new cancer therapy, where I think with immunotherapy there's this idea that this is fundamentally different than everything else we've had before. This is the direction that the field's going in, and there's sort of a consolidation of research and resources sort of around this one sort of therapeutic idea. And I think one of the things that sort of drove us to sort of make these statements, particularly for urothelial cancer, is that if you look at the data objectively, immunotherapy actually doesn't look that different from any other sort of therapy. It's obviously an improvement, but in terms of the actual patient benefit, it's not dramatically different from other drugs. If you look at sort of the response rates, if you look at the duration of response, there again certainly improvements, but the idea that these are sort of very fundamentally different in terms of how patients will respond, I think is maybe a little bit flawed. And so the focus on this sort of class of drugs exclusively, while I think everyone hopes that there'll be improvements that lead to these long-term durable responses and that lead to a higher percentage of patients responding and that sort of are real game changers in this disease, which is a really bad disease. I don't know that that's going to be the case based on the existing data. And so, there are other, you mentioned antibody drug conjugates, there's other sort of modalities that are sort of very actively being explored that, may ultimately have more of an impact. And so I think that that's sort of something that, we sort of hope to suggest by the study as well.
I think Dr. Shoag gave a great summary. And I think, there's a lot of interest in some of the new medications like antibody drug conjugates, either alone or in combination with ICIs. And I think a lot of work is also being done on predictive biomarkers to sort of, really hone in on those patients that are really going to benefit. And I think the field of genomics and, genomics as a predictive biomarker could be very revealing, and could definitely open doors for a lot of patients who would benefit even more from ICIs. So I think there's a lot of interest, and I think it's very exciting, and I'm looking forward to seeing where we end up in the next couple of years.